Welcome to the Sustainable Clinical Medicine Podcast. I am your host, Sarah Smith. I am a practicing rural family physician and the charting coach. This is the podcast for physicians and advanced practice providers who are ready to step back from the busyness of their clinical day to share ideas, question everything, and redesign their clinical day. We are redesigning clinical medicine to create sustainable clinical days and create time for our lives outside of medicine. Join us for discussions with world experts who are helping design sustainable models of clinical medicine and the physicians or clinicians who have discovered or designed sustainable models of clinical medicine for themselves. Hello, everybody, and welcome back. I hope you are having a wonderful day. Today we have with us Dr. Stephen Beeson, who is going to introduce himself, then we'll hop into some conversation. Welcome.
Great. Thanks, Sarah. Yes, as mentioned, I am a family medicine physician, born and raised in San Diego, California, and have spent the majority of my time in the exam room, as well as transitioning to a physician leadership position with a large integrated healthcare system in California and San Diego. Became very interested in the process of how do we develop clinicians to both contribute to better medicine and define joy and contentment in the journey and create durability in that effort. So now I have sort of dedicated my life to that endeavor as I've transitioned from managing a 2,200 patient panel to now leading tens of thousands of clinicians in the journey of the clinical life.
Nice. Okay. So tell us about medicine, its journey, what got you into family med, what kind of happened along the way?
Yeah. So the intention early in my life was not to be a physician. I was not one of the ones that in elementary school said I wanted to be a doctor. And in fact, my decision to go into medicine was after I finished high school, which is not super convenient given how hard it is to get into undergrad and medical school. But I had an uncle who was a neurologist, and I had a chance to spend some time with him after finishing high school, at which time I wanted to be a trumpet player and musician. And I had a dinner with him when he was out here visiting from Ohio, out here in San Diego, and he told me about a day in the life of evaluating, diagnosing, managing, interacting, connecting, treating, and advancing patients' journey to health and wellness. And I said, that sounds like an amazing life. And so ever since those dinners with my uncle, following that, I spent a couple of summers with him, working in all sorts of different environments. He was an attending, so I got to do rounds with the medical students and the residents and the fellows, and I got to work in the ED and got all sorts of sort of early clinical experience. And he also ran a headache clinic, and so I got really good at managing headaches. And he was a brutal attending for me, constantly challenging me for the cranial nerves and neuroanatomy, and would ask me questions right alongside the fellows who were doing epilepsy fellowships. And so I got lots of early exposure to medicine, and that just really lit me up. And from there, I pivoted from music to medicine and ended up getting an undergraduate degree in biochemistry and cell biology from University of California, San Diego, and ended up getting into medical school at University of California, San Diego. Did my residency at University of California, San Diego, and finished in the mid-90s and joined, as I mentioned, a large system, Sharp Healthcare, here in San Diego. And that's sort of how I got to the beginning of the clinical journey.
Wow. Okay. So you were doing music formally and kind of hanging out in the summer with uncle? Is that
Yeah, it was a transition. I mean, I'm sort of a binary person. So when I switched from music to medicine, it was a full-on switch. And I went from practicing etudes and range studies for 4 hours a day to fully engulfing myself in all the undergraduate requirements to be able to apply to medical school. And I was pretty far behind because in high school, I was just studying music. So my SATs were pretty good, but my GPA was probably could never get me into school today because it's much more competitive today.
Okay. Tell me about this binary piece, because that's kind of fascinating that you can kind of drop music to do this other thing. Do you find that's common? Is that something you knew about yourself?
Well, people say music to medicine, what a wild switch, but it's really not that
Mhm.
different. Both are mastery journeys where you
Mhm.
learn and grow capacities and abilities and knowledge and skills to achieve something. So I switched the intention, but the process was very, very similar. And the idea of exerting effort to raise the capacity to execute something was very, very transcendent in going from music to medicine. So I just switched my chassis and turned the steering wheel a little bit
Yeah.
from etudes to biochemistry. So, but it was the same process.
Interesting, very interesting. What was it about family medicine that drew your attention?
Well, I love to see the front end of disease when
Mhm.
people come in with a composite of symptoms and a pattern of presentation and the nuance of the clinical story to render a differential test against it and define the diagnosis and to longitudinally connect with a patient.
Mhm.
I found the early days of medicine, I was like, diagnose, treat, and cure disease. That was like the thing that I tallied as I am making a difference in the world, my ability to diagnose, treat, and cure disease. And then what I realized as I walked through, nearly 20 years of clinical practice is that between chronic disease and self-limited disease and functional disease and terminal disease, my capacity to diagnose, treat, and cure disease was a very small portion of the time. And so that was actually a pretty notable frustration for me. And managing hemoglobin A1Cs and LDLs and blood pressures was fun and everything, but what I really discovered my joy and contentment in medicine was establishing longitudinal relationships and finding out who these people are and what they want to achieve and how do I help them get there. And in addition to you know really taking great pride and exquisite histories to find the nuance of the story, to find the root cause of their symptoms. So I said it's sort of a maturation process. I went in thinking that diagnose, treat, and cure disease was what doctors do.
Mhm.
But then what I found later on in my life is the ability to build these unbelievable relationships with colleagues and with teammates and with patients was really the thing that sustained me, that allowed me to continue to do this long term.
Interesting. Where were the struggles? What were the difficulties as you did the stages of this career, do you think?
Well, there were a number of things that were really challenging for me. And when I talk about the transition from I'm a diagnostician that treats disease to advance wellness, which is the entire reason I went into medicine. That was the thesis. And then contrasting that as to what clinical practice is actually like, which is at best incremental intervention. Right? We're sort of
Mhm.
incrementalists, right? That contrast was remarkably depressing for me. I thought, I'm not able to do the things that I define as success, which is find a diagnosis, treat a diagnosis, and watch a patient become well, was a very small portion of the time. And I was managing chronic disease, which is medicine. It's 70% of all of healthcare is chronic disease management. And I found that to be just a grand disappointment compared to my illusion of what I thought medicine was going to be. So, and there was just experiences I had along the way that allowed me to find patients where we utterly clinically failed in terms of our ability to diagnose, treat, and cure disease. But still, even in that context, and I don't mean failed like we made an error, but
Mhm.
medicine failed, like young women who had widely metastatic breast cancer despite really appropriate and aggressive therapy, and watching and being beside families who lose everything,
Mhm.
or patients who have catastrophic illness, or patients who have hemorrhagic aneurysms where we end up losing them. I mean, there are things that are very, very difficult to predict. And during those times of loss and times of tragedy and quote failure of medicine to be able to treat and intervene and cure, uh, were some of the most impactful moments I'd ever had as a clinician. And I was able to be beside them and to walk this journey with them, to go to the memorial, to do home visits, and to stand beside them. Uh, and I realized, you know what, we can diagnose, treat, and cure disease occasionally, but we can really make profound impact in the lives of patients all the time by
Mhm.
how we show up. And what I found was, yes, patients benefited, families benefited when I showed up in a compassionate, connecting, curious way that allowed me to really understand what mattered to them. Uh, but the greatest beneficiary was me. I was the greatest beneficiary. I became that clinician in that moment that I became super proud of. I go, God, you know, yeah, I made a difference. And that's, I just thought when I was young and relatively naive that diagnose, treat, and cure disease was the metric to make a difference. But then as I grew and matured and went through really difficult moments of realizing that medicine is not what I thought, and walking into these really, really difficult circumstances where I had a chance to make a difference, even in the context of loss, that I was able to widen the aperture of how it is we're able to make a difference. And there's incredible power in that because we can control who we are when we walk into that exam room. And there's now at last count 57 studies that have been done demonstrating that when we deeply connect and compassionately connect to the patients that we serve, and we are living into the purpose of what we envision for ourselves, it is profoundly beneficial for our experience as clinicians. So that's sort of what got me to what I'm doing now was
Mhm.
all those bumps and bruises and discoveries of being a young physician.
Mm. I still see the pain of physicians when they're holding tight the expectation on themselves that their patient does well or improves their health or is cured, right?
Yeah.
That desire to impart enough of themselves that the patient improves or is cured, and the holding tight the outcome,
Yeah.
right, for the patient.
Right. It is. I mean, and it's not an unfair standard we hold ourselves to. Meaning, I will do everything I can based upon my experience, my training, my knowledge, and my intense focus and presence in front of the patient to do the best and right thing according to evidence to optimize their outcome. And if they don't have a good outcome, I will carry that personally. And
Mm.
uh, although that's noble, it's there's a couple of things about that. First of all, it is important that we're really good at what we do clinically. I think it's our first and foremost responsibility that we listen carefully, that we take great histories, that we read continuously, we learn from colleagues. Yes, yes, yes. Um, but I think that the thing is that if we deploy evidence-based medicine to do the very best we can, and the patient doesn't do well, uh, we can't carry that. And also, I think that the thing that I really learned, and I think what the evidence supports, is that if you ask patients how they define the best clinician ever, like the best ones they've ever had in their entire lives, they will say three things. They will say, uh, "I want a physician who really cares about me."
Mhm.
And I want a physician who really listens to me and what matters to me. And the third is I want a physician who really includes me and keeps me in the know. And what's ironic is that patients define the greatest clinicians ever, not by our clinical capabilities, but how it is that we interface with them so they feel cared about, they feel heard, they feel included, they feel participatory, where we really identify what matters most to them. And of course, we will bring the very best of what medicine has to offer to get the right diagnosis, the right differential, the right testing, and the right treatment plan to optimize the outcome. But patients, first of all, they can't assess our ability to do that well. They have no real capacity to say, you are technically a sound physician. They have no idea what we're doing and whether we're good at what we do or not. So even if we were the best, but we didn't flip the switch for how patients actually assess a clinician, which is cared about me, listened to me, included me. Though that's how the patients define a great clinician. So, getting back to your question, I think being the kind of clinician that walks into that exam room that brings compassion and kindness and listening and curiosity and getting to know, what about all that you're going through right now worries you the most? And tell me a little bit about you and what you want to achieve. The clinicians that gives those kind of signals of warmth and compassion, as well as competence, the patient will walk out and say, gosh, even in the absence of a cure, which doesn't usually happen, the presence of that person who showed up in that way, that physician who did that way, made a profound difference in my life, gave me hope, gave me a sense of confidence that they know what's going on. They really identified what mattered to me and what my fears and worries and goals are. And a clinician who shows up like that, the patient will walk out and say, well done. You enriched me. And as I referenced, clinicians who show up like that and are deploying the actions, the activities, and the skills and the behaviors that convey I was cared about, I was listened to, I was included. Those clinicians are going to go home at the end of a day, even a really busy day, and say, "Man, I was good today. I crushed it." And it's in part how hard we work, but it's much more the conditions that we work under. And I always encourage clinicians to, in some ways, let it go. We do the very best we can for the patients to show up emotionally in a connected way, and we will do the best we can clinically. And that is all we can do.
Mm.
And their grief is not ours. We can't bear that. We can't carry that on our back. And
Mhm.
clinicians need to learn that their grief is not ours.
Yeah, yeah. I'm going to have people thinking, I want to connect with my patients. I want to have that expectation to give them the opportunity to be cared about and listened to, and I get given 10 minutes.
Yeah, right. Well, it's you ask a great question, and I would contend, first of all, I've spent a lot of time studying and researching and writing and practicing and shadowing. What are the things based upon evidence that prompts the patients to walk out and say, "The best, you are
Mhm.
amazing"? It's not the amount of time we spend with them; it's what we do when we're in there. And so there's only one study that I'm really aware of that finds a differential between the top decile and the bottom decile in terms of time differentials, and it's about a 70-second differential, which is notable. I mean, that's not trivial. But most other studies find that it's not how much time you are spending with the patients; it is your presence, your capacity to send signals and behaviors of "I hear you." It's our ability to say words and take action where the patient says, that physician really cares about me. And another important thing is that we say things and do things that render patients' confidence in us. And so when the patient's really confident in us, and they know that we care about them and that we're really listening to them, um, I can do that in less than 5 minutes. And I was able to achieve the 99th percentile in the patient experience as one of the busiest, largest panels in our group. And I did it for a decade straight, working less hard than a lot of other clinicians by deploying a couple of simple evidence-based activities that prompted the patient to feel really heard, really cared about, and really confident in me. Not in an arrogant way, but he really seems to know his stuff. And I feel good about the journey we're about to take, and I'm willing to participate in it. And he cares about me and what matters to me, and he really listened to me like no other clinician ever has. Those are actually pretty simple things to do that don't take a lot of time.
Mm.
So I only have 10 minutes. I get it. It is. It's busy as hell out there, and having a big administrative load in particular can distract us from that human connectivity. Uh,
Mhm.
but I would also contend that it's what we do in the exam room. And having shadowed almost 1,000 clinicians over the last 20 years, meaning watching them,
Mhm.
what they do right in front of me, even with the bias of me, a coach, being in the room, they still don't do it. They still don't do the very basic blocking and tackling of human connectivity in that exam room. So to get back to your question, I only have 10 minutes. It's mostly because clinicians have never developed the skills on how to connect really quickly and effectively to patients to render not only a really good clinical history, but also for the patient to walk out and say, you're the best, and the clinician to walk out and say, oh, I crushed it. That's good.
Mhm.
Yeah.
Okay,
So,
I like this. And what I like about this is it's that hope that this is or that the understanding that this is a trainable, teachable skill. You
mhm,
can learn it. It isn't going to take you an additional 20 minutes in the room, that this can be fast, but it is a skill. So it's that understanding that, hey, if I'm not connecting, if I'm not walking out kind of, I did a good job, just notice that what Stephen's saying is this is teachable, this is
right,
trainable. Thousands of
right,
physicians are able to come out of the room going, yep, I feel connected to the patient. The patient's going, yep, great doctor.
right.
Right.
You
I
know,
think that's really
it,
helpful, because sometimes we hear these ideas and these journal articles and we're like, yeah, but you don't understand the
right.
pressures I'm under and this time crunch. And now I've got to make patients happy because I'm showing up with a better tone. Okay, so now this leads you into my next question. You're busy, you're seeing lots and lots of patients every day, you're doing it for decades. How do you keep it together? How do you be that person in the room? What are you doing to look after you so you can show up in that way, or are you putting you aside? Like, how does it actually go that you can keep this pace, this connection going? Is
Right.
it just that you're enjoying it, or is what else is going on? Tell us the kind of background.
Well, there's what I refer to as a soil that allows clinicians to have durability and contentment in their lives. And I think there's four things, of which we spoke about one of them, which is deep connectivity to patients using evidence-based skills that can be learned and trained, not as a class, but human development is a longitudinal journey of mastery for which we are never done. So, so the four things are certainly patient connectivity, and again, powerful evidence that when we deeply connect, authentically connect, it reduces burnout and restores a sense of purpose and wellness and uh, um, authenticity, meaning we are living in accordance to our belief system. We are being who we know we should be in this healing life. So patient connectivity. The second one is team collaboration, which is perhaps an even greater impact on the durability of anybody in this clinical or any work life is my teammates have my back and we help each other, we support each other, we lift each other, we laugh together, we tease each other, we dive in if somebody's struggling, we know each other's, the hopes and dreams and fears and worries, and building that, and we're amazing teammates for each other. And within the clinical microsystem and across clinical microsystems, within and across teams, where we build a cultural trait of we just are there for each other. And we you can't expect a clinician to be deeply connected in a sustainable way if they walk out of that exam room into an infighting, dysfunctional team that doesn't help and support and lift each other. It's unsustainable. So part of the soil is deep patient connectivity, yes. High team collaboration as a cultural trait expectation and as a set of trainable skills. Uh, we can train clinicians and people to be highly collaborative, amazing teammates. And there's one study that shows that my teammates have my back is the single greatest correlate to workplace engagement across every industry. So team collaboration. The third is leadership effectiveness, meaning how the organization is being led. So uh, leadership is not to dictate and mandate and assure productivity and to hit revenue targets. The role of leadership is to lift their people, to help them become their best. And so highly effective leaders, there's 12 competencies that make for amazing, amazing leaders. Self-awareness, growth mindset, multiplying leaders, Liz Wiseman's book, where we enable the people that we lead to bring forward their ideas, low authority gradients, compassionate, grateful, authentic, vulnerable, leaders who can speak with candor, who model behaviors, who listen and respond, who deburden. The composite of leadership behaviors, manager and above within a healthcare system, will enrich the soil to allow those that are delivering care to say, I feel heard here. I feel appreciated here. I feel supported here. And yeah, there's still a lot of stuff that we could fix here in this healthcare system, but our leadership team, they're amazing. They're rounding on us. They're listening and responding. They include us in decisions. They empower us to make local solutions to the challenges that we have. They appreciate us. They thank us. And I feel really good about my existence here based upon how my leaders are leading. And the teams are amazingly collaborative. We collaborate, we help each other, we support each other, we have low authority grades, we have psychological safety, and we're about serving a mission bigger than any one of us at the team level. So we're effective leaders, highly collaborative teams, deeply connected to patients. Those are three things. And so connect, collaborate, and lead all have to be in place. You can't take one of them away and expect durability and the quality of the clinical life. The fourth thing is our ability to take care of ourselves. And that's been a very important part of my journey. I didn't always do it. And what I found was my care for self capacitates me to live this life at my fullest. And so when I'm done with this podcast, I'm going for a run. I don't really feel like it because it's kind of hot and muggy here in San Diego, but I am going. And eating right and sleeping right. And physicians are going, oh, give me a break. I don't have time to go to the bathroom yet, let alone do all those things. But having lived a life that's really, really busy, not taking care of myself, and living a life that's really busy, busier now than I've ever been in my whole life, when I spend 40 minutes a day, 30 minutes a day, achieving a VO2 max of 42, which is, again, O2 uptake measure, then I feel ready. And, I sleep right and I eat right. And I meditate and I try to be present in the moment. And so taking care of self, deeply connecting to patients, collaborating with colleagues, and being in a place that is highly effectively led. Those are the four things that I think represent the soil of the clinical life. And you dash one of those away, and you're going to get what we got now, which is a bit of a crap show in regards to the experience of clinicians across this country.
Yeah. I can hear a lot of people and their ideas about their leadership. Now, when we talk about leadership, and we can talk about like the big deal leadership of maybe an organization, but then we have like little microcosms of teams and leaders. And I think that sometimes we may not be able to change the bigger, wider system, but we might be able to change our local environmental leaders.
Well, no, it's a very important issue. And we call this leader cohesion, meaning there's a way of leading that is proven to engage and lift the people that they lead. And that is how we lead at this organization. And leader cohesion is so massively low across most healthcare systems, where leaders have wildly variant approaches. Some are fixed mindset, some are growth mindset, some are command and control, some are people pleasers, some can't communicate, somebody doesn't want to speak the truth at any time. So, it's all over the place. And just like clinical variation applied to a disease is bad, so too is high leader variance, where leaders are highly variant, and everything distal and downstream from an ineffective leader is going to be frustrated, disengaged, unappreciated, a whole bunch of things that prompt them to say, it sucks here, by the way. Medicine is hard enough with highly effective leaders and really collaborative teams and really deeply connecting organizational culture around what's right and best for patients and connecting in that exam room, and our ability to prioritize taking care of ourselves. Even when all those things are in place, medicine still has tons of challenges. But I would say of all those things, connecting and collaborating and leading, that leadership has the most impact on what it's like to be a clinician in a clinical life. And there is, again, wild variance. And again, I've spent my life now applying human development to raise the capacity to achieve things, and believe that developing leaders on evidence-based human engagement skills and mindsets and strategies is a mechanism to reduce your turnover and engage your people. You can develop the skills of how to become amazing teammates for each other. And you can develop the skills of connecting to patients. You can even develop skills of taking care of yourself. And, as you reference, you hear a lot of clinicians pulling their hair out regarding their leaders. It's because their leaders are really inconsistent in regards to doing what's best and right for the people that they lead to help them lift, soar, and ascend and become their best. That's sort of where we are right now. So,
yeah, beautiful. Right. So tell us about your journey. Did those whole 20 years of clinical medicine, were we doing and growing and mastering? Was there times when it was not going so well, or like why the transition?
yeah. So around about 7 years into my clinical practice, I was appointed to a position to lead an organizational change effort. At a time that organization was struggling on things like patient connectivity and team engagement. And so I became interested and tasked with, how do you help our organization become better for patients and better for teams? Pretty notional objective. And so I had no idea how to do that. So I began the journey by asking patients, how do you define the best clinician ever? And they gave me a clinician who listens to me, who cares about me, who includes me, who keeps me in the know, all the basic, simple things. And then I dove into the evidence to say, what are the behaviors and actions that are proven to render those experiences for patients? And then I began to coach, train, and develop them with myself and with my colleagues. And what we found was we were able to take patient experience from the 6th percentile to the 93rd percentile using a people development skill building strategy. And then we began to widen the aperture a little bit with team collaboration skills and then leadership effectiveness skills. And then over the course of time, we were able to take patient experience, team engagement, talent retention, clinical quality, financial performance, and just cultural proxies to an organization that was having flashing yellow and red lights to one of the best there was anywhere in the nation. Winning the Malcolm Baldrige Award. And the principal intervention was developing our people continuously and at scale to deliver the behaviors that reflected what we wanted to become for our patients and for each other. And so along that journey, I was still managing my patient panel, and I was doing it a half day per week. And I wrote a couple of books, one book called Practicing Excellence, that has now ended up selling over 300,000 copies on the physician manual to exceptional healthcare. Wrote another book called Engaging Physicians, a manual to physician partnership, how do leaders engage physicians in an organizational change journey. And then around 2013, I was sitting in a Starbucks with my life spinning wildly out of control because I was managing a 2,200 patient panel. I was coaching and training care team members at Sharp, and I was being asked to come to healthcare systems to say, we want to develop our clinicians to help us execute the kind of outcomes that you guys got. And all three of those are an FTE. And
Mm-hmm.
so I go, I can't continue to do this. I'm going to explode.
Mm-hmm.
So sitting in that Starbucks, I was thinking, the process of developing people to raise their capacity to execute outcomes works in patient connectivity, team collaboration, and leadership effectiveness. But it's also really hard to scale. It's really hard to sustain. It's really hard to map that development to a specific organizational outcome. So I thought to myself, and those incredible results took us a decade, took us 10 years to get those results. Nobody has a decade to do anything anymore. So I thought to myself, how could we use technology to power continuous skill building and learning?
Mm-hmm.
Um, and ended up founding a company called Practicing Excellence, name of the book that I wrote, that uses a technology-enabled skill building using a micro-learning approach deployed across an enterprise that maps specifically to an organizational goal and intention. And now we're servicing tens of thousands of physicians, nurses, APPs, and leaders and clinical teams using a human development approach to execute outcomes. And so, although that was never my intention to be a founder of a company, I had no idea, again, how to do that. And I made lots of mistakes along the way. But I knew that people development to raise their capacity to be their best and to live in accordance with what they believe in and to make a difference in the world. And that process of mastery as a enzyme, as a catalyst to achieve something is way better than a financial incentive, way better than I'm going to hold you accountable for your KPIs. Developing people to raise their ability to execute something is, I believe, a necessary organizational effort, whether it be leadership effectiveness, team collaboration, or patient connectivity. A human development strategy is necessary to achieve organizational outcomes. So that's what I do now and how I got here. Again, not intentional, very accidental, and here we go.
Yeah, yeah.
Now I'm founder of a company.
That's
So,
right.
yeah.
Yeah. Well, I can see that over the course of what you were doing over that decade, you are becoming an expert in watching for and teaching the skills to increase capacity in the areas you're talking about, right? Increasing the ability to connect with another human, to create an amazing team, to foster some leadership skills that look beyond self and look wider. I mean, that practice, your brain was just growing so fast in this area that you became an expert in it.
Well, yeah, it was an accidental expert.
Yeah.
And when I first began, nobody knew the idea of coaching a clinician to help them become better. That was Atul Gawande came up with the great article in the New Yorker about, his coaching journey, but that was much, much later. This is 10 years before that. And so the idea of provisioning skills, and what I found early on is that I was given my first order of business from our board who was saying, hey, Steve Beeson, why don't you go, we'll have you the director of this improvement effort, and why don't you go help all the bad doctors become less bad and help us as an organization to get better? So I go, oh, okay. So again, I started with myself. I had to coach myself before I could really coach anybody else. But then when I met with these clinicians, and the coaching criteria initially for our group was those clinicians in the first percentile or below in patient experience. So, and there was actually a lot of them, sadly. And when I met with these clinicians, a couple of things that I observed. First of all, none of them were doing it intentionally. They had no idea what they were doing that was prompting the patient to say what they were saying about them. Number two, they were crushed by the data coming at them. So I have now learned that provisioning individually attributed data without help and support to become better is cruel. You can't
Mm-hmm.
do it. You can't say we're gonna make our data transparent and we're gonna give them 10% of their year-end bonus based upon patient experience. I said, you better be giving them tools because they don't even know what they don't know. They have no idea what to do in the exam room to prompt the patient to walk out and say, you're the best. And so,
So important,
oh my
Seamus.
God,
So
yeah.
important. Holy cow. I hear the heartbreak and the I don't even want to look at it for their press ganies. Like they don't even want to look.
It is. It's awful.
Heartbreaking.
Half the clinicians that I coached were in tears.
Yeah.
And to be told by a patient, don't trust you,
Yeah.
don't understand you, wouldn't recommend you. It's
Mm-hmm.
like, what the fuck? Really? I mean, do you think I'm trying to do this? I'm trying really hard to do what I've been trained. We're
Mm-hmm.
holding people account without giving them help to become better. And so in those moments with those individual clinicians who were in tears, I go, no, 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 we can't do that.
Mm-hmm.
And also the beauty of helping and supporting them with simple actions that they can take and to watch them soar
Mm-hmm.
is, you know, it is an amazing experience to be able to do something that makes a difference in the life of somebody else. Even it may sometimes it's a patient, sometimes it's a colleague.
Mm-hmm.
And to give you an example, I remember one ophthalmologist I was coaching who was super awkward socially, but a brilliant man, an ophthalmologist. But his patients just didn't get him. And so the skill that I provisioned for him, as I said, I want you to take a moment and find out who the patient is. What do they work? What do they love? What are their hobbies? Just, find out, be curious. And I want to check back with you in a week. And when I met with them, he had this epiphanal moment where not only did he discover that he was taking care of amazing people with amazing stories, and what that was like for him to go from diopters and intraocular pressures to
Mm-hmm.
the manager at Sony who just had to lay off 24 people because their manufacturing is going on overseas and how heartbreaking that was for the patient, that he was able to form and forge a connection that fundamentally changed how patients experienced him. And he walked out of the exam room knowing not only the diopters and their intraocular pressure, but the human
Mm-hmm.
that is going through life in that moment. And it takes seconds. And so the provisioning of these simple things to clinicians as an adjunct to the data, because I understand that it's a data-driven world, but so frequently we become so obsessed with patient experience data that the metric actually becomes our mission.
Mm.
That we're saying we need to get 92.4. No, we don't. It is the patient experience data is a consequence of the only thing that matters, which is our capacity to connect with the people that we care for. When we do that based upon proven behaviors in the exam room, I 100% guarantee you that your patient experience scores don't improve a little bit, they are transformed. And if we invert that, make the metric the mission, that is a process that we call surrogation. And it destroys the authenticity of the journey. And it's a byproduct of this immense regulatory environment that we're in right now. And why my favorite oxymoron that I made up, which is regulating excellence, it never happens by virtue of demanding that healthcare systems achieve a metric. And great leaders will understand that we have to provision kindness and compassion for every patient every time. That is who we are and what it means to be us. There's a set of behaviors and skills and experiences that we will deploy and develop in the exam room that will manifest and be consistent with that commitment. And we will measure and check. as a child, if you will, not the parent, as a child, the metric of patient experience to see if we are doing what we intend to do. So anyway, yeah, there's a lot of mismanagement of data. There's a lot of overlooking of the power of developing people. There's a lot of provisioning of individually attributed data without providing help and support, which is no wonder why clinicians struggle so right now.
Yeah, yeah. I also like that comment about the team collaboration and the soil, because that analogy is so perfect. The clinician might be doing a fantastic job, but if the secretary had an attitude when they were checked in, it's reported, right, about the experience. And so this we matter, as in every patient, every time matters. Every one of us is part of the care of the patient, and you matter, team, as part of the care of the patient. Then you can see how it's not just put on the physician to be their best in the room. It's on the team to be the best every day for every patient, because we want to increase that care towards our patients, right? And so it's that the soil matters.
Right. The soil matters, that we're all in this together. There are ways of being and kindness and compassion for every patient every time, from security to phlebotomy to physical therapy to transport to hospitalists to ambulatory physicians. It's just who we are. And it's deeply embedded. It's continuously developed. It's measured and assessed in the appropriate way. I want to tell a quick story regarding the importance of team collaboration. We had done a study a number of years ago showing the impact of when clinicians feel as though they have high collegiality and collaboration where they are. It had like a 60% impact on burnout probability. I mean, massive, massive impact of those clinicians who felt they were in a highly collaborative, friendship, collegial work environment had a radically lower probability of burnout. And just to give you a sense of how this can play out, I remember when I was a young clinician, we had a interventional cardiologist that was a bit intimidating for everybody. Super smart, really academic, and would speak with great candor in regards to how you were doing things. And he's amazing. He just retired, in fact. And I remember I was a young family medicine physician, and I get a call from him where my nurse comes in and sticks her head in the room. She said, "Hey, Doctor wants to speak with you." Once you pulled out of a room, I'm going, "Oh my God, what can he possibly be wanting to say to me?" So I walk back to my office, I pick up the phone, and I pick the phone, and he says, "Steve, this is David." And I won't share his last name, but he said, "I just want to let you know that atypical chest pain palpitation patient that you sent to me as a consult, well done. Exactly the workup I would have engaged in. A really clear and appropriate workup, a really clear question, and the patient and the family love you. And I just want to let you know it was an excellent consult with a really great workup." And that, to me, as he could have, in that moment, I was probably 31 at that time. That was a belonging cue. Steve, you belong here. You're one of us. I respect you. I honor you. I value what you do and who you are. He could have, with a different set of words, destroyed me. It made me feel like I am an imposter. I don't belong here. I'm not good enough. I'm not smart enough. And David, in that moment, expressed through his words and actions belonging that allowed me to feel different about who I am and how I reside, in a sense of collaboration. So this is what collaboration is. We look out for each other. We honor each other. We lift each other up. We check in if somebody's struggling, and we appreciate each other. We pull each other aside and say, "You freaking killed it. That was so good. That was so good." And being in that culture, we can do anything. But you take that away and you make it difficult and challenging and isolating and lonely, and people are out stabbing their backs and not helping each other and yelling at each other, then I don't know if I can get through a week like that. So building this sense of collaboration is immensely important, just like leadership effectiveness and just like patient connectivity and just like, taking care of ourselves. All of those I think we have the capacity to express those and achieve those by helping our people with the skills and the capacity to connect and collaborate and to lead in this journey.
So helpful. Really good. Where do people find you if they're looking to connect?
Probably you just go to our website, which is practicingexcellence.com. And it's probably the easiest way to learn about the work that we're doing. I'm on LinkedIn and happy to connect that way. And I love talking to people about, how they're approaching, healthcare challenges and patient experience and team engagement and leadership and those sorts of things. And we've had some breathtaking results in the application of human development to achieve things. And we're just getting started.
Perfect. Anything we didn't touch on that you'd like to share or leave us with as we wrap up today?
I think my last, words of wisdom, I don't know, is this a weird word, but is, we get to choose who we are in this life. There's a lot of extrinsic stressors that can be overwhelming if we look on the horizon in American healthcare. It is overwhelming. What I would encourage as an adaptive strategy, as a durability strategy, is to focus on who do I want to be in this life for my patients, for myself, for my colleagues as a leader. I choose that. Nobody can impact that but me. I get to choose how I am showing up.
Mm-hmm.
And that's power. And in fact, I'll finish with one of my favorite quotes from Viktor Frankl that said, between stimulus and response, there is a space. And in that space is an opportunity to choose our response. And in that response lies our growth, our freedom, and our power. And Viktor Frankl was a survivor of Auschwitz. So there you go. So
yeah.
Anyways,
Totally.
I think that we need some power to choose our life and who we're going to be in this journey. So I guess I'll leave with that.
Beautiful. Thank you for this conversation. I really appreciate your time this afternoon. I think we're going to get some hope and some strategy that we can totally start to have that choice in our spaces. So thank you so much. I really, really appreciate you being here.
You bet. Thank you, Sarah.
Okay. Bye. Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca. There you'll find all the information on the Premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done, with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.